So now that we have understood how to evaluate a glandular function or in a question statement whenever there are levels of hormones given, the next best step as pertains to the question statement I've given you, that first step is to assess the hormonal levels. Usually in the question they will give you hormone levels, so you need to know whether it is a hypo or a hyper level. Once you have defined that the patient is having low levels or high levels, then you do a suppression or stimulation test and thereon and so forth. Now let's go into the individual glands and let's see if we can see the hypo and a hyper pattern and try to understand how questions can be framed around them. So pituitary, anterior pituitary and posterior. So the pituitary, the anterior pituitary hormones are the growth hormone, uh, ACTH, TSH, LH, FSH, and prolactin. The posterior pituitary hormones, as I told you, they're neurotransmitters. They are oxytocin and arginine, vasopressin, or antidiuretic ADH, antidiuretic hormone. Most of these hormones, as we previously discussed as well, they are under trophic stimulation, except prolactin. So always remember, prolactin is primarily under a inhibitory control of dopamine. Now, it is important why there was a question, I think 2 years back, that there is a lady who has come to you uh, with amenorrhea, secondary amenorrhea. So she hasn't had any menstrual periods for last 6 months. The only history that they are getting it that she was evaluated for dyspepsia 2 years ago and was found to have H. pylori positive and was started on PPIs and prokinetics. She is being she has been taking these medicines for last 2 years on intermittent basis. The initial treatment she took for H. pylori for 14 days, and thereafter she continued to take PPIs and prokinetics. So, what is the next best step to perform in this patient? Can anybody give me an answer? One line. So, what is the diagnosis here, and what is the next best step? Any idea? So, a lady comes to you with a history of no periods in 6 months, that is secondary amenorrhea. She is on treatment with PPIs and prokinetics, that is, uh, lesuride or etopride or something like that, along with the PPI, that is pantoprazole or something like that, for last 2 years. What is the diagnosis here, and what is the next best step? Come on. So this is basically prokinetics induced hyperprolactinemia. Why? Because prokinetics like metoclopramide or cisapride or lesuride, levosulpride, that is, all of them, they are anti-dopaminergic. So because they're anti-dopaminergic, they suppress the dopamine and they increase the prolactin. And prolactin makes sure that the periods are not there. So prolactin makes sure that the lady or the female is not ready for pregnancy as yet. Prolactin is a nature's way of preventing another pregnancy while the lady is feeding the previous pregnancy or the previous child. So as long as the mother is feeding the child, usually it should not happen that she gets pregnant again because she does not get ovulation. And the ovulation is suppressed by prolactin. And because ovulation does not happen, that is why not come. So the diagnosis, suspected diagnosis here is prokinetic induced hyperprolactinemia and related to secondary amenorrhea. And the next best step, the blood test to be done is serum prolactin level, so they will be elevated. Is that all right? This is how the questions will come in the exam. Okay. So most hormones are primarily under the stimulation except prolactin, which is under the inhibitory control of dopamine. And whatever will inhibit dopamine will lead to release of prolactin. Hypothalamus controls the pituitary via two processes, the trophic processes or the factors and inhibitory factors. Now, conditions which lead to dissociation of the hypothalamus pituitary axis, like trauma, like encephalitis, like meningoencephalitis, a direct injury to the hypothalamus pituitary axis, like transaction of the pituitary, they all lead to increased secretion of prolactin but decreased secretion of all the hormones. So the anterior pituitary, if it is alive and rocking, and the axis is broken, the hypothalamus pituitary axis is broken, the pituitary will increase the production of prolactin because now it's not getting any inhibitory stimulus from hypothalamus in the form of dopamine, and it will suppress all the other hormones like ACTH, like FSH, like the growth hormone, everything, because they are under the effect of releasing hormones coming from the hypothalamus. Is that clear?
Yes, sir.
So now we move on to anterior hypopituitarism. So whenever we read endocrine uh, glands, we always do the low function first because it tells us the deficiency symptoms of a hormone. So hypopituitarism, now anterior hypopituitarism. So we will just focus on the anterior part of the pituitary. So this is anterior pituitary. Now, if somebody had to decrease the production of anterior pituitary hormones, they would have to do one is break the hypothalamus pituitary axis. Second, there are cells responsible for secretion of different trophic hormones like adrenocorticotropic hormone, like thyroid stimulating hormone. So all of them are different cells. Let us say there is a one type of cell which overgrows the other cells, known as an adenoma. So it suppresses all others. This will also lead to hypofunctioning of the gland in terms of those particular hormones which are suppressed or compressed, the cells of which are compressed by the enlarging adenoma. So those lesions are known as pituitary adenoma, and because if you look at the skull, there is hardly any space for anything else rather than the brain itself. So if pituitary, which is supposed to have this much size, develops an adenoma and tries to, increase its dimensions, then it will press upon the adjoining brain, which cannot go anywhere because the skull is a closed cavity. The brain cannot go anywhere. Hence, there will be headaches. And because there is a, if you look at this diagram clearly, the orbital nerve, optic nerve, it decussates, it crosses just above the pituitary. So when it grows wild, the pituitary adenoma, it compresses on the chiasm, the optic chiasm, and hence it leads to bitemporal heminopia as well. So the patient will have headaches and they will have visual field defects, plus they will have symptoms of hypofunctioning pituitary. So these are known as pituitary macroadenomas, which if they are larger than 1 centimeter, they are called pituitary macroadenomas, and if they are smaller, they are known as microadenomas. So pituitary adenomas more than 1 centimeter are usually non-functioning. They are macro, and then if they are smaller than 1 centimeter, they are known as microadenomas, and they are very notorious because all of them are hyperfunctioning. They are secretory adenomas. Then these patients in pituitary, they not only can have a adenomatous lesion, but they can have something else also, like a bleeding vessel, which has bled here and has led to, hemorrhage inside the pituitary. So this hemorrhage will obviously, compress all the functioning cells and lead to hypofunctioning. situation. Another thing that can happen is a metastasis. So a tumor from somewhere else enters here, and then it takes away all the space. Then other malignancies like meningioma, germinoma, glioma, chordoma, these are, although they are benign, but then they can have a mass effect on the pituitary cells. Rare lesions like Rathke's cleft, they can also have a compressive effect on the cells of the pituitary. Then, of course, the pituitary is a vascular structure. There can be vascular lesions like an intracellular aneurysm. So, what is cella? Cella is a space in the skull which has pituitary placed in it. So, if there is a cellular tumor placed somewhere here, the tumor compresses the pituitary from outside. Again, it will lead to hypofunctioning of the pituitary, which can be an intracellular aneurysm. It could be a bleeding that has occurred into the extra pituitary cellular space. It could be subarachnoid hemorrhage. It could be Sheehan syndrome. It could be the tumor itself can bleed to occupy the space. So pituitary tumor apoplexy as well. Then comes inflammatory lesions like sarcoidosis, tuberculosis, syphilitic granuloma, granuloma with polyangiitis, that is Viginous granulomatosis, or lymphocytic hypophysitis. So all these lesions can present with hypopituitarism because they will compress the pituitary from outside. So whenever I always say, whenever there is a condition that you have to draw a differential diagnosis on, you should follow the principle of vindicate always. So vindicate is basically vascular, infectious, neoplastic, degenerative, iatrogenic, congenital, autoimmune, traumatic, or endocrinal. So all you have to do is fill in whatever fills in your mind, and then you will get a list of differentials. So these are all the list of differentials which lead to hypopituitarism by mass effect. That is compressing on the pituitary. And the presentation will be with headaches, visual side effects, and of course, hypofunctioning pituitary. Then there are other conditions which are enzyme deficiencies, which are usually congenital problems. They do not have a mass lesion. For example, somebody does not congenitally have secretory cells for growth hormone. They will have growth hormone deficiency, isolated growth hormone deficiency. Sometimes they will have a condition known as septo-optic dysplasia where the pituitary cells are not formed. So there is no need for something to compress pituitary. It is the cells which are not just there. Congenital hypogonadotrophic hypogonadism, gene mutations that lead to progressive loss of anterior pituitary function. So these are all the conditions that do not require a mass effect. They can just produce hypopituitarism by lack of production of the hormone because there are no basic structure present for that, like the cells. And then there are certain conditions like Angelman syndrome, or Prader-Willi syndrome, which are a genetic disorder, showing a paternal or maternal chromosomal aberrancy. If the paternal chromosome gene are deleted, it's called P for paternal, P for Prader-Willi, and of course, if the Angelman becomes the maternal chromosome is hypofunctioning. So in that case, pituitary hypofunction is present, malfunction is there, and the condition is referred to as the loss of, referred by the name of whichever chromosome is lost. So if it is paternal chromosome which is lost, it is Prader-Willi, and if it is the maternal chromosome is lost, it's called Angelman syndrome. Then comes the Kalman syndrome, where gene mutations have occurred, and it basically Kalman syndrome, there is problem with the ciliary movement of the cells during blastophase phase of the cell formation. So these cells, they stop migrating. The cells of gonadotrophin releasing hormone synthesizing neurons, they just do not migrate from olfactory bulb to the hypothalamus. Hence, in Kalman syndrome, there is anosmia and there is infertility because there is lack of gonadotrophin releasing hormone. Another conditions are congenital growth hormone deficiency and certain clinical conditions like patients who are on chemotherapy. They take some drugs which suppress the pituitary synthetic function. Then pituitary surgery, then cranial radiation therapy, encephalitis, cerebral malaria, hemochromatosis, autoimmune disorders, post CABG leading to ischemic necrosis of the pituitary, so traumatic injury. These are clinical conditions where there is no mass effect, but the patient has hypopituitarism, uh, and which was not present from childhood. From childhood, if it is present, it is congenital. Then there are other conditions which also present as hypopituitarism, but they are known as functional hypopituitarism because you just do not find any pathology to explain the hypopituitarism. One is, of course, anorexia nervosa or malnutrition. So these patients, they like patients of chronic kidney disease, opioid therapy, even patients who are undergoing normal aging, they get growth hormone deficiency. So depression, lack of appetite, lack of excitement, lack of libido, all these things they happen. But as such, the pituitary is entirely normal. It's called functional hypopituitarism. Similar things happen in anorexia nervosa. uh, Anorexic women, they usually become amenorrheic. The reason being there is deficiency of luteinizing hormone and follicle stimulating hormone. Serious illness can also do that. Sometimes traveling away from the family can also do that, but that is of course not associated with malnutrition. That is called hypothalamic amenorrhea, which is severe emotional or physical stress, intense exercise program, bulimia nervosa, anorexia nervosa. They can all lead to hypothalamic dysfunction leading to amenorrhea. Again, the therapy with certain agents like leuprolide, they lead to gonadotropin releasing hormone that can persist even after when the therapy is stopped.